Hey everyone, and welcome to this explainer. Whether you're a first-year MBBS student or just brushing up, today we are going on a seriously fascinating journey through the respiratory system. I'm absolutely thrilled to be your guide as we master the lungs. We're going to take you all the way from their gross, macroscopic features right down to those highly functional microstructures. And most importantly, we're going to connect the pure anatomy you see in the dissection lab directly to the clinical applications you're actually going to use every single day in the hospital.
Okay, let's dive into this. Our roadmap for today covers an overview of the lungs, contrasting the right and left sides, exploring the mediastinal surface, checking out the root of the lung, and finally breaking down the bronchopulmonary segments. Section 1. Overview of lung anatomy. Imagine for a second that you're holding an embalmed lung right there in the anatomy lab. What exactly are the basic boundaries you're feeling? Well, the lung is kind of conical, right? It has this rounded superior end called the apex, and surprisingly, that apex actually extends about 3 centimeters above the first rib, right up into the root of the neck. At the bottom, you've got the base, which is concave because it sits perfectly right on the dome of the diaphragm. As you run your hands over it, you'll trace 3 distinct borders: the anterior, posterior, and inferior. You'll also feel 2 main surfaces, that outward-facing curved costal surface and the totally flat medial surface. Now, looking at the trachea and lungs from a direct anterior view, you really start to notice the differences in those borders. The anterior border of the right lung is, quite straight and vertical, but look over at the left lung. It has this really prominent, wide cutout. That's the cardiac notch, and it's literally there just to make room for the heart. Right below that notch, there's this tiny, tongue-shaped projection of lung tissue called the lingula. Locking in these anterior features is going to help you instantly orient the lung during your practical exams. Section 2. Right versus left lung. In anatomy, contrasting 2 structures is literally the best way to lock them into your memory. And trust me, this is highly testable stuff. The right lung is your larger, heavier organ, weighing in at around 700 grams. It's packed with 3 distinct lobes, the superior, middle, and inferior. And those are separated by 2 fissures, the oblique and the horizontal. Now, the left lung, because it's sharing space with the heart, is smaller and lighter at about 650 grams. It only has 2 lobes, superior and inferior, and they're separated by just a single oblique fissure. So what does this actually mean in the ER? Well, let me give you a classic clinical scenario to think about. Why do inhaled foreign bodies, say a swallowed peanut or maybe a small piece of a toy, why do they almost always end up in the right lung? The answer is right here when you look at a bronchoscopy view. Notice how the trachea bifurcates or splits right at the carina. The right principal bronchus is shorter, it's wider, and it runs much more vertically. It only deviates about 25 degrees from the trachea. Meanwhile, the left bronchus is narrower, it's longer, and it branches off more horizontally at a 45-degree angle. So because that right bronchus is practically a direct, straight shot down from the airway, it becomes the path of least resistance for literally any aspirated object.
Section 3. The mediastinal surface.
Let's mentally flip the lung over to check out its medial surface. This side is divided into 2 parts. You have a small posterior vertebral part, which simply rests against the spine. But then you have this massive anterior mediastinal part. Think of this mediastinal surface like a giant mold of wet clay that's been pressed right up against the heart and the great vessels. And since the heart is asymmetrical, the impressions left in that clay are completely different on each side. The right lung molds around the right atrium, the superior vena cava, and the azygos vein. The left lung, on the other hand, molds against the huge left ventricle, the arch of the aorta, and the descending aorta.
Section 4. Root of the lung.
Right smack in the center of that mediastinal surface is the absolute gateway of the respiratory system. But first, let's clear up a massive trap for first-year students. The terms hilum and root are not the same thing. Actually, scratch that. They're often used interchangeably, but anatomically, they shouldn't be. The hilum is simply the physical area. Think of it as the doorway on the medial surface of the lung. The root, however, is the actual bundle of structures, the bronchi, the vessels, the nerves, that are actively passing through that doorway to connect the lung to the mediastinum. Now, memorizing the order of these structures inside the root is absolutely crucial for your exams. For the anterior to posterior arrangement, which thankfully is exactly the same on both sides, we use a super simple memory trick, VAB. Moving from the front to the back, you're going to find the superior pulmonary vein, then the pulmonary artery, and finally the bronchus all the way at the back. Just remember, VAB. Seeing this mnemonic in action visually really helps it click. Looking at the anterior hilum, you can clearly spot the red pulmonary veins right up front. Just behind them, in that middle layer, are the blue pulmonary arteries. And situated most posteriorly, you can see the tough cartilaginous rings of the bronchi.
But wait, the top to bottom arrangement is where things get just a little bit tricky, because the two sides are actually different. On the right side, the principal bronchus divides super early. So reading from top to bottom on the right, you've got a bronchus passing above the artery. That's called the eparterial bronchus. Then you hit the pulmonary artery, and then there's another bronchus below the artery, called the hyperterial bronchus. On the left side, though, the bronchus hasn't divided yet. So from top to bottom on the left, it's just the pulmonary artery on top, the left principal bronchus in the middle, and the inferior pulmonary vein at the bottom.
Section 5. Bronchopulmonary segments.
All right, we are zooming way in now. We're moving from those big macro lobes down to the highly functional micro units known as bronchopulmonary segments. So what exactly makes a segment a segment? Well, it has to meet some pretty strict criteria. It's a specific pyramidal-shaped subdivision of a lobe, and its apex always points inward toward the hilum. But here is the most important part. It is completely functionally independent. It gets aerated by its very own tertiary bronchus. It's supplied by its own unique segmental branch of the pulmonary artery, and the whole thing is completely surrounded and isolated by its own layer of connective tissue. When you map these all out by international convention, there are exactly 10 recognized bronchopulmonary segments in each lung. Think of this grid as a universal GPS map for physicians. Whether a doctor is looking at the apical segment of the superior lobe, or maybe the lateral basal segment of the inferior lobe, this standardized system allows doctors literally anywhere in the world to communicate with pinpoint precision about a patient's lung pathology. And here is the ultimate clinical payoff for learning this complex map. Because every single segment is an independent unit, walled off by connective tissue, a localized disease like tuberculosis, a benign tumor, or bronchiectasis is very often restricted to just one single segment. This is a huge deal. It means a skilled thoracic surgeon can go in and perform a segmental resection. They can carefully dissect out and remove just the diseased segment, while leaving the rest of the patient's perfectly healthy lung tissue intact to keep doing its job.
So I want to leave you with this thought. The anatomy you are memorizing right now, it isn't just a list of vocabulary words for your finals. It's the fundamental blueprint of the human body. As a future doctor, how will mastering these boundaries, these roots, and these microstructures today change the way you read a subtle shadow on a chest x-ray, or how you might plan a life-saving surgery tomorrow? Keep that in the back of your mind the next time you step into the anatomy lab. Thanks so much for joining me on this explainer, and keep studying hard.